We are going to get right in to Dr. Pierre Kory's presentation. We're very excited to have him here. He has presented a dynamic session at the live Fellows Track Symposium involving actual ultrasonographic images on live models that he correlates with clinical care, the best evidence about ultrasound, and pearls, tips, and best practices that you can take and use in your work out there in the units, in the clinic, in the emergency department, et cetera. As means of introduction, in addition to being a phenomenal speaker for the Fellows Track Symposium over the past many years, Dr. Kory is an associate professor of medicine at the University of Wisconsin School of Medicine and Public Health. He's the critical care service chief at the UW-Madison hospitals and the medical director of the Trauma and Life Support Center. In addition to those and many other roles, again, Dr. Kory has a wealth of information and research about ultrasonography in the critical care and trauma setting. So with no further ado, Dr. Kory, thank you so much for being here. The participants may put in questions in the chat as we go through things. We'll try and keep an eye out for that, and either interrupt if they're critical or hold them to the end as they build up, if there's time for questions. Again, thank you so much for being here.
Hey, thanks, Sharon. I really appreciate the introduction. I hope everyone can see my slide. Let me see. I split this into two talks. Anyway, so hold on. Let me say a couple of things. So Jeremy gave me a lovely introduction. It's good to be here. Not so good to be on Zoom, but we'll make it work, guys. That's number one. Number two, I should mention I forgot to change my credentials. I am no longer at the University of Wisconsin. I have moved on, and I'm going to be doing something different. I joined St. Luke's Aurora in Milwaukee. So anyway, goodbye, University of Wisconsin. Hello, Milwaukee. I have to update all my slides because those have been like that for years. Anyway, so guys, today this is what I want to do. I'm going to go a little bit over what sort of point of care, really critical care ultrasonography is. And then I just want to try to cover what I think is the highest impact applications of ultrasound in the ICU. And that's really two things. It's the differentiation of shock states. That's like the mainstay of what I use ultrasound for in the ICU. I use it for lots of stuff. I mean, I look at eyeballs, I look at peristalsis, I'm always looking at the bladder and kidneys. But the mainstay is really trying to figure out why someone isn't perfusing or why they're in shock. And then the second thing is to differentiate respiratory failure states. And so I want to go over like the kind of the algorithm that I use in answering those two really important and ever-present clinical questions, right, guys? You all know in the ICU, we're constantly trying to figure out shock and respiratory failure, and sometimes both, right? So that's why I call this ultrasonography in the management of cardiopulmonary failure. Okay, so let's talk about echo first. Number one, I love this slide. This is kind of weird talking. I'm used to an audience where I can get a little feedback and people can raise hands. And so I'm just going to talk by myself in my office, and I'm going to pretend that you guys are laughing and having a good time. Jeremy's smiling, so I'm getting a little bit of verbal, visual feedback here. So yes, exactly. He's saying that I'm doing okay. So here, I like to start with this slide because I find this slide really funny. So if any of you watch this show, and I don't really watch medical shows, but for some reason, this one grabbed me. It's called The Nick, and it's about a surgeon. Actually, he's cocaine addicted. It's a cocaine addicted surgeon in 1905. And I just was really captivated with the operating room scenes. And this is a picture from an operating room scene. And one of the reasons why I like it is just to show you how far we've come. So I sometimes ask the audience, I say, where is the cardiac output monitor in this scene? How are they operating without a real-time, EKG tracing or an arterial line? And the joke, really, the answer is it's the nice little nurse with the little hat on who's actually documenting, and I assume her other hand is actually like on the pulse on the carotid. And throughout these scenes, you're getting this verbal feedback all the time where they're saying like bounding, irregular, faint, thready, and then you'll hear like absent. And when they say absent, guess what happens? They don't break into like a whole big CPR routine. They actually put down the scalpels and they walk away because CPR wasn't invented at that point. And so absent is not a good thing. And then I try to think of like the modern ICU. If you just had like pulse checkers at every bedside and you didn't have our monitors and like you just have people like calling out all the time, bounding, faint, thready, and you guys get my joke. I've probably gone too far on that joke. But anyway, the reason why I bring this up is because ultrasound is a form of a cardiac monitor, right? It really gives us a wealth of information information. And that, we've always had that in medicine. We're always trying to find out more and more information about the underlying physiology of what we're seeing. And, the first cardiac output monitor was actually the pulse. That was the very first thing that was ever invented to try to get a sense of what's going on with perfusion. So similarly, right? Technology has come from, this is in the Korean War when you got an X-ray, you had to wield this whole big thing to the bedside. We really don't have a lot of tools at the bedside diagnostically until ultrasound, right? You could get a bedside X-ray. Thank God we don't have a bedside CAT scanner, because if we did, oh my gosh, everybody in the country would be glowing because every doctor would order a CAT scan every 2 seconds. But we do have ultrasound, and you get to examine any number of organs right at your fingertips and right at the bedside. So that's me in my shop doing an ultrasound there. Why isn't this advancing? There we go. Click. And then we get even smaller, right? So this is me being a geek. I got like a tablet ultrasound, and I built like this forearm holster, and I used to walk around on rounds with my tablet-sized ultrasound on my forearm. And my joke is about half the house staff thought I looked really cool, and the other half thought I looked like a really big geek. And then I stopped doing that. Anyway, so you guys get it. So a lot of you, listen, you guys are fellows. Nowadays, wherever you are in fellowship, first year, second year, third year, you've used a lot of ultrasound. It's now filtering down to, into residencies more and more, and even into a few medical schools. So, I'm going to skip the physics of ultrasound, but just to take a second here and look at just the amount of information that you can see with one quick image, right? And compare that, if you will, to like a stethoscope, right? So what you're looking at here, can you guys see my mouse, right? You guys can see my mouse, Jeremy? You can see that? You can't see like my mouse pointer? Oh, you can. Okay. So that way as I point stuff out, I know that the audience can see it. So right here, guys, this is the diaphragm, and the head is here and the feet are here. So this is the person almost like laying down in a bed, right? And so this is a diaphragm. Anything to the left of the diaphragm is the thorax, right? And this is the lung. And this is, the lung can give you a really pretty picture when it's sick. When it's well and it's full of air, you can't see anything, right? You see those A lines. But when it's sick, and this is what I call a bag of pus, right? So whenever you see a lower lobe like this, which is just consolidated, which it looks like the liver, it looks like a solid organ. Remember, you don't want the lung. You guys should know at this point, right? The lungs are best full of air, not full of pus. Yeah. Okay, we're good with that. Okay, so this is what I call a big bag of pus, right? And so it's a terribly ill patient. And whenever you see this kind of consolidation, like this huge, massive, like hypervolemic lower lobe, I got to tell you, you don't even need a culture. It's generally strep pneumo. It's been my experience. So don't even send a culture. Just make sure you're treating strep pneumo here. And then so you guys get the sense, right? So imagine putting your stethoscope here. What would you hear? Well, if you were really cool, maybe you could hear like a gophony, or you would hear bronchial breath sounds, right? Or you would just hear dullness, and you'd wonder, is it an effusion or what is it? But here you put an ultrasound on there, and you know immediately this is not an effusion. This is a big, dense consolidation. And then you see these white parts, and you see those little bubbles. So air is really reflective. So it tends to become very hyperechoic. And this is air trapped in the lung. And so this is what we call, these are static air bronchograms, and this is a dynamic air bronchogram. So as the patient's breathing, right? So the diaphragm descends, you see like air going in and then exhaling out. And so you're able to see these. And I just think it's a beautiful image, and it just tells you a lot. Like this is 100% a pneumonia. This is not atelectasis. This is a pneumonia. And you guys might be able to ask me that later. What's the difference between atelectasis and pneumonia on ultrasound? And generally it's hard to tell, but it has to do with volume, right? Atelectasis denotes volume loss, whereas a consolidation is really sort of a hypervolemic lobe, and you have to look at a lot, but this is really just a big bag of pus. So anyway, I just love these images, and I talk about them. Let's define point of care ultrasound. There's a number of definitions. I kind of have my favorite, which is the last one. But, some are as simple as it's just an ultrasound exam performed by the guy or gal who's providing the care, right? So it's in real time. You're using it to create an internal image, and then you're going to use that in your decision making. And then there's other things that we define it as. And, I generally, it's not a complete study. In fact, that's almost against the rules for me. In that, especially when I differentiate shock, there is what I would call a complete goal-directed study, which is a number of images and a number of questions that you have to answer, but it's not a comprehensive echo, where they answer, comprehensive echoes, I usually go off on them, but they answer questions nobody's asking, like the velocity in the pulmonary vein of the blood. It's really bizarre what they do. But here, in point of care ultrasound, we have a really, sometimes a very narrow question and a narrow series of images that we need to do. And so we're just directed at answering one straightforward question. So it's not not about scanning everything so you can bill CMS for a comprehensive exam, right? So it's a very practical one. And then for me in the ICU, and this is why I love critical care ultrasound, this is why I became sort of an expert at it and I got so drawn to it, is because as opposed to the ER or on the floors, boy, when patients get sick, the ultrasounds become really critical and actually relatively easy to interpret. The sicker someone is, the less subtle it is. And so we're not looking for subtleties in point of care ultrasound, especially in the ICU when patients are dying. If they're dying of something, it's usually evident on the ultrasound, right? And so I like this answer, which is, or this definition, which is geared to addressing highly time-dependent and focused questions. And in general, most focused scans become more obviously positive as the patient becomes increasingly unwell. And I remember that as I'm doing scans. Because if you're like hedging and hawing over the LV function in someone who's dying, guess what? It's not the LV function, right? Because if the LV function was a problem, it would be absolutely clear, okay? And so just one of my tips. And then, very similarly, right, in unstable patients, right, it directs immediate care. And in stable patients like the ED, they really just do it to expedite care, whether they have to admit someone, whether they have to do more of a full workup. So they're using it to kind of prognosticate and see what's there. They're not always doing it in unstable patients. You think that the emergency medicine is like all sexy and they deal with all these emergencies all the time. It's really not. It's actually kind of boring a lot of the time, especially when I've seen their image sets. You have no idea how many normal images emergency medicine doctors look at. They look at so many normals, and then you go up to the ICU, there's no such thing as a normal scan, because usually when I'm breaking out the ultrasound probe, it's on someone who's not normal. And so we become really expert at the abnormals. Okay, so what are some of the benefits? And this is really important, right? Every pathologist or radiologist, they want to know everything about the patient in order to inform their interpretation. And guess what? Most of you do a really bad job of that when you order those tests, like pathology tests or radiology tests, right? You'll say like SOB in the, in the indication, shortness of breath. It doesn't give them really a lot of context. And when you know the context of the patient, it really helps you understand what could be going on in the images, the kind of things that you want to look for, the kind of things that you might emphasize. And so the clinical dissociation of traditional interpreters, gets bypassed, right? You know exactly what's going on with that patient and what your question is. The other thing is it avoids time disassociation, right? When someone's crashing at 2 a.m. and you want to look at the heart or an echo of the lung, you don't have time to order, an official study done by a sonographer that the images then get, interpreted later. You don't have hours for that. And so, especially in critical illness, the time disassociation part is really critical. And then the other thing, which I love, is that we can do any number of things. I can look at multiple organs at the same time. And so my other joke is, have you guys ever tried to order at the same time an echo, a chest ultrasound, an abdominal ultrasound, and a DVT study? And then you have probably the director of the ultrasound lab call you and absolutely try to crucify you. So we don't do that, but I don't have to ask for those 5 tests because I can do them. If I think there's, a right heart failure and I'm worried if there's a DVT or trying to understand something, I can do quick looks of all of those. And so it allows you to do, what I call WUBU, which is whole body ultrasound, WBU, and you can sort of span a number of organs all at the same time. And then obviously, and number 4 and 5 should be 1 and 2, meaning avoiding potentially lethal radiation and avoiding potentially lethal costs. Right? Costs are running away from us in medicine, and radiation. There's a number of people who think that we're going to have an epidemic of cancer in 10 or 20 years, right? Because everybody who sneezes in a hospital gets a CT angio to rule out PE, and it's going to come back and bite us and bite our patients. So don't get me on my PE bandwagon. Okay, but I'll tell you, do an ultrasound before you order a CAT scan. That's what I would say. It would cut down on a ton of CAT scans. Okay, now the history of how we did it at the bedside, and I'll go back to my first slide, right, guys, about talking about cardiac output monitors, right? So remember, in what defined critical care for decades was the Swan-Ganz, right? That was the pulmonary artery catheter. And what's interesting is, in a lot of countries in the world, right, intensivists come from different specialties. So a lot of Europe, intensivists tend to be anesthesiologists, right? In this country, almost all of us for a long time were pulmonologists. And in France, actually, a lot of them were cardiologists. And so that's actually kind of the birthplace of critical care ultrasound, is that the cardiologists started going in the ICUs. And remember, they have, the old hammer nail analogy. Right, their hammer was the echo, so everything was a nail to them, and they echoed everything, and they started, actually looking at stuff that wasn't their heart. Could you guys imagine a cardiologist who actually had a thought about another organ that wasn't the heart? Jeremy, this is where you're supposed to laugh. This is where usually I get a little laughter, but I'm not hearing anything. So, and also I'm not allowed to make fun of other specialties, so it's specialty bashing. But I try to do it with a lot of humor, guys. But the cardiologists in France, they really kind of invented the specialty. And what they actually found, which is really interesting, is they found that they believed their echoes much more than the Swan-Ganz catheter. And that was the beginning of the end of the Swan-Ganz, as they realized that, that categorization of shock that Swan-Ganz pressures led you to believe often were erroneous, and they made a lot of mistakes. And so they basically very quickly retired the Swan-Ganz in order to use echo. And that's what we're going to talk about in this first half, right? And then you guys could see emergency medicine picked it up, the surgeons with their fast exam, and then in the ICUs, we really started bringing it to the bedside. And like I said, now it's kind of percolating everywhere. And then sort of now every specialty in point of care ultrasound, they have at least one application of ultrasound, right? I would say critical care, we have way more than this. We probably have the most in emergency medicine, but every specialty does. And so ultrasound isn't owned by anyone, right? That's actually a statement by the American College of Physicians. It's basically, it's within the competence or capability of any trained physician. So don't think that you're stepping on anyone's territory when you're using ultrasound. It's a tool. It's a tool just like a stethoscope. All you need is training and how to use it. And I got to tell you, it's going to help you to become a better doctor. And that's one of the things I say about ultrasound is that I firmly believe, and I am not confused by the fact that it absolutely makes me a better doctor. I know more about my patient. I know it sooner than anyone else, and I'm able to integrate it in ways that I know leads me to more correct decisions. I've been doing this for almost 20 years, and I just know you put me in an ICU without an ultrasound, and you put me in an ICU with an ultrasound, and there's two different doctors operating. And so what my vision is for the specialty is that we all come out of fellowship and training as what I would call sono-intensivists, and that's really what you really should strive for, is becoming a sono-intensivist. Again, this is some of the statements in support of ultrasound by a number of societies. And then Abraham Verghese, right, because I sometimes can be dismissive of the physical exam. I don't want to put down the physical exam, but I just feel it has limitations in the critically ill. And he's the last of the great champions of the physical exam. He's really great to listen to. And what I love about him is he loves point of care ultrasound. He thinks it's he almost likens it to the physical exam, right? Instead of a stethoscope, it brings you to the patient, lays hands on the patient, and it adds volumes of information. And so even the great father of the physical exam believes it's important. The rationale evidence is difficult. It's very difficult to amass evidence for a diagnostic test, but there's countless numbers of case reports. All of us who use it, we know how it helps us in a daily basis in making good decisions. And the other thing is there's also lots of other outcomes that it does. It saves money, efficiency, time. It keeps you from going down other diagnostic rabbit holes. It tends you to focus your thinking. And so I think some of the really benefits are a little bit hard to measure, but they're out there. So like, for instance, this is one where they trained a group in lung ultrasound, and what they found was there was a 50% decrease in the year afterward. I don't know why this is jumping around. After they learned how to do lung ultrasound. And then in two ICUs in one system, one ICU where everybody used ultrasound, the other ICU, this is like maybe 10 years ago. They published it 5 or 6 years ago, but the data came from before that. And there was this one ICU where they really didn't use any ultrasound. And when you compared the two and you looked at how many X-rays and CAT scans the two ICUs did, I mean, it was magnitudes different, 3, 4, 5 times as many other diagnostic tests as those who used a lot of ultrasound. So it makes you much more efficient doctor, I believe. Okay, so let's go to the meat of this. Let me see my time. That's pretty good. It's 15 minutes in, and I went through my introduction. And like I said, guys, what I want to do in the next 45 minutes is I want to cover how I use basic critical care echo and lung ultrasound to answer the two questions, right? Which is, why is this patient in shock, and why is this patient in respiratory failure? I'll talk a little bit about fluid responsiveness, although I got to tell you, as magical as ultrasound is and echo is, absent the extremes, echo and ultrasound are just not really good to answering that question, should I give my patient fluid? My general answer to that question, if you're asking it, the answer should be no. unless you have a really good reason to give fluid. And that's sort of where I've come in my career, which is, the days of like, you see someone in shock on pressors, you give them 1 liter, you give them 2 liters, someone gives them 3 and 4, and then you're like, wow, they're still going up on pressors. Maybe I should give them 5 and 6. Hopefully we're moving away from that. If it didn't work the first couple of times, the 3rd, 4th, and 5th liter are unlikely to work. And remember, most of the time we're dealing with vasodilatory shock. In fact, 75% of our shock states are vasodilatory. And really, that's not to be treated with fluid, right? That's to be treated with vasopressors. So anyway, so let's talk about the heart. And then if you look at this slide here, right, this is just sort of like, it's a new kind of nomenclature. These are the new physical exam findings that you should become fluent with, right? This is the new language or the dictionary that you should use, right? And so here you have these, A lines, right, which is dry lung. And then you have what called B lines, wet lung. And then I showed you what a consolidation looks like. And then there's a variation of fluid. So this is like an air fluid ratio, right? And then there's things like lung point that you can use to detect pneumothorax. And then similarly here, right, you can look at IVC, which I'm going to say in this slide, it overstates the importance of the IVC. But then here you find all sorts of different pathology when you look at the heart, which can help you to figure out why someone is deteriorating in shock on you, right? And so this is sort of some of the signs that I'm going to go over now in this lecture. Okay, now if you were to look at one slide in this entire first half of the question, of the first goal, which is, differentiation of shock states. This is the most important slide. And so I sometimes make a joke like, what we do in the ICU is categorically and qualitatively different than cardiology performed echo. The questions that a cardiologist asks of their echo are categorically different than ours. What is the most common question they ask? Well, the most annoying and sort of redundant one is, what is the EF, right? They're constantly asking what the EF of the heart is, but they're asking it for very different questions, right? They're oftentimes managing patients in chronic heart disease, right? They're worried about different impacts of medicines or different insults to the heart. And so they're really very big on the left heart, right? And then they also have valvular questions, and sometimes they have sort of cardiac output or function questions. But generally, it's really just structural questions that they have. Whereas for us, I would argue if you were to grab the next cardiology fellow that you saw, and if you grabbed them, and I always sometimes make a joke, if you grabbed them by the lapel and you said, hey, what are the 6 different echocardiographic patterns of shock? What do you think the chances are that he would be able to rattle these off? Very, very low, okay? And this is why conceptually this is different. We're asking a different question. When we put the probe on the chest and we look at the heart, we're asking, why is this patient in shock, okay? And when you look at this, the descriptions of these patterns, right? So these are the main causes of why someone would be in shock, right? So number one is, are they completely volume or fluid embarrassed? Meaning, are they completely dry to such an extent that they're no longer able to perfuse? Their cardiac output is so low. That is readily determined on echo if they're really in extreme state. The one challenge to basic echo is that hypovolemia and early sepsis have a lot of overlap. That's sort of like the one holy grail that we still struggle with, guys, in the ICU, which is differentiating hypovolemia from sepsis. And when you look at the heart, it's oftentimes very difficult because they can look very, very similar. So clinical context is important. But LV failure, guys, like I said before, it's not subtle. If someone is in shock because the LV is not pumping, it is going to be readily apparent. You're going to see an LV that's generally dilated and very hypocontractile with very little movement towards the center. RV also, if someone's dying from an RV problem, it's not subtle, guys. That RV is going to be screaming at you from the screen. It's going to look at you. You're going to see a big rounded RV, bigger than the LV, right? You're going to see some influence on the septum, right? And then tamponade also. The easiest thing about tamponade is to rule it out, right? So if you do an echo and you don't see a fusion, well, guess what? You can knock that off your list, right? You don't have a tamponade. Tamponade, remember, is a clinical diagnosis. It can be helped with ultrasound, but it can't be made with ultrasound. And I have to tell you, another pet peeve I have in medicine is anytime someone sees an effusion, they immediately ask a cardiologist to look for echocardiographic signs of tamponade. And I really feel that's just improper. I think it's helpful. I think we all want some evidence before we start to drain an effusion or put a catheter in someone's chest, and I get that. But remember, it's still a clinical diagnosis. The echocardiographic signs can only be supportive. They can't actually rule it out. There have been patients in tamponade without echocardiographic signs. In fact, I've drained a number of them in my career based on the clinical diagnosis. But I will say this one very simple teaching point. If you see a big effusion and you're wondering if they're in tamponade, look at the IVC. And I'll tell you why. Unless that IVC is big, plump, and invariable, if it's anything but that, they're not in tamponade. So you can pretty much rule out tamponade pretty well just by looking at the IVC. The other stuff is a little bit more subtle. And then here on the acute massive left-sided, I actually, in my medical ICU practice, I've only had one case where a valve was the proximate cause of shock, and it turned out in hindsight it wasn't actually the valve, it was a chronic valve problem. So that's actually a very rare a cause of shock, and so I don't usually advocate color. I don't do a lot of color Doppler in my echoes. Basically, everything's qualitative, just 2D imaging. And then obviously the more interesting thing is doing echo in CPR, which I actually believe it should be TEE, and I routinely do TEs during CPR in the ICU. Outside the ICU, it's a little hard to do that. But if we're going to do CPR on someone in the ICU, we generally drop a TE probe, but that's for another talk. Okay, so you guys saw this differentiated shock state. Now, what's interesting is on this slide, which comes from sort of one of the landmark papers, it's 2000 and it was from 2009, which is basically the competency that you needed to do basic critical care echo. The funny part is it's written by my mentor, and he forgot to put the most common pattern of shock. It's not on here, guys. And what is the most common pattern of shock in the ICU? It's actually what I call normal echo shock, meaning when you look at the heart, the LV looks at normal size, it's pumping okay. The RV is normal size, it's pumping okay. There's no effusion, and the IVC is normal-ish. And that's what I would call a normal echo. So when you see a normal echo, that is actually defining probably vasodilatory shock. It tells you it's not a heart problem, and it's more of a peripheral endothelial problem, right? So it's not on here, but I think in your mind you should think of that pattern. That's a very common pattern. In fact, most shock states in the ICU are more consistent with what I would call normal echo shock. And that actually is on this slide, right? So here, this is from 2012. This is the last kind of review paper on shock in the New England Journal. But here, what I like is this is almost historic, right? So I talked about it in my talk earlier, right? This is like in the NIC, right? 1905, they just had like a pulse, right? They did physical exam. They looked at the skin and they checked the pulse, right? And then for years we started using pressures with either Swan-Ganz, right, or central lines where we did CVPs, and then we kind of evolved over time. And now really the gold standard is echocardiography. This is how we differentiate shock states. So this is sort of the more modern slide on that prior one. And in this monograph in the New England Journal, they did include what distributive shock is defined by, which is generally normal cardiac chambers and contractility, right? And we'll go over some of these. So this is, and I already bashed the comprehensive echo. I just find that it's inappropriate in the ICU. It's actually one that's built more for, I think, billing and for like a whole breadth of cardiac problems. And it's not really focused to a specific issue, right? And that's why whenever anyone orders a comprehensive echo, if you ever look at a report, it has about 120 pieces of data on there. They make all these crazy measurements that nobody looks at, ever. What do you look at when you look at at an echo report? You're looking at the same 4 questions that we answer with a focus. What's the LV doing? What's the RV doing? Is there a big valve problem, and is there an effusion? And so, again, comprehensive echoes have very little role. I do order them if I have something of concern or I have a question that's not answered by myself. And also, I do not pretend to be an expert at valves. In fact, I try to be a really good expert at knowing large global structural problems with the heart, but valves is just way beyond my expertise. And that's where you really need to know anytime I have a valve question, boom, I ask a cardiologist and echocardiographer. I think that's outside the scope of an intensivist. Now, how do we answer these questions, and what are the questions? So you guys are familiar with all these different acronyms for goal-directed echo, and they're all great. There's what is it? Rush, pump, tank, pipes. There's free, feel, fate, falls, feces, beat. No, there's no feces, but you guys get what I mean, right? And what are they doing? They're sort of answering different questions. And if you're in the emergency room, it depends what your scope of practice is. So some people really, right, if you're in the ER, you're going to throw in a fast. If you're doing a lot of trauma, you want to see if there's any free fluid in the belly, and you also want to check out the aorta. But in, like, let's say a medical intensive care unit, for me, for differentiating shock, I'm really just looking at the heart, right? Unless I'm worried about a pneumothorax. But generally, people don't come in with traumatic pneumothoraces once they're already in the ICU, right? So if you're not doing trauma, I generally just look at the heart for the questions. And so this is what I would call a goal-directed echo, right? Which is 5 views and 5 questions that you're trying to answer. And so what are the views? The general 5 views. Remember, a comprehensive echo probably has 12, 15 views that you could do. We kind of stick it to the big 5, right? And so the parasternal, and this is beyond the scope of this talk to go over the anatomy. Hopefully a lot of you already are familiar with these views in the anatomy at this point, but you guys get it, right? These are the 2 parasternals. You have the long axis and the short axis, right? 90 degrees, so you can see all 4 walls, and this is along the length of the LV. And then we have one where we put a point at the apex, and now you can see the 2 chambers side by side. And then this is the subcostal, where you're kind of shooting it from the RV anterior wall, a little bit under the RV, and you can see this way. And what I find in critical care echo is that if I don't have good parasternals, I tend to have good subcostals. And vice versa. Sometimes I get lucky and I get everything, but just keep in mind, in the hyperinflated patient, sometimes the air comes in front of the heart and you can't find the heart parasternally. But what's nice about the subcostal is when you stick the probe in the subxiphoid, right, you're using the liver as a window, right? So that little strip of liver, that lobe of the liver that comes across, and the heart sits on top of it. Now you can sort of peek around the hyperinflated lungs by looking at it from below. And so, this is what we call the bailout view. A lot of times you can get really good information from the subcostal region. And then obviously the IVC. So these are the 5 views. Now, what are the 5 questions? Well, the 5 questions for me are, what's the LV doing? What's the RV doing? Is there an important pericardial effusion? What is my sense of volume? And I generally can't answer that definitively unless, well, you can answer it with lung ultrasound. Actually, lung ultrasound is better at detecting intravascular volume in a lot of cases than the heart is. And then really just a gross look at the valves. Anything that catches my eye with the valve, is there an aortic valve that's not opening, or is there something, flapping around in the mitral valve? And those are kind of the 2 most important. So the first thing that we do, right, is we ask ourselves, what is the LV function? And the way in which I do it, and let's look at this parasternal, right? So this is the LV, and the 3 things that I do to answer for function is I first look at endocardial excursion. So you want to look at this, that white stripe, which is that inner part of the myocardium, the endocardium, and I look to see how far that wall goes to a point in the center, right? So I put my eyes at a point in the center, and I see how far the wall goes, and it should go about 40 to 50% of the way towards that point. Another thing that I look at is you actually look at the thickness of the wall, and you want to see if it thickens by about 40% or it thickens at all. If I see thickening, it's usually very reassuring that the contractility is preserved. And then the other thing that you look at is you look at this anterior mitral valve leaflet. If you see this leaflet flying open, it comes very close to the septum, that tells you that the cardiac output and the stroke volume is likely intact, even though that's a diastolic measure, right? The mitral valve opening is diastole, but what's interesting about diastole is that, what goes out of the heart has to come into the heart. So if you have good filling of the heart, it means you probably have good emptying. And I'll show you that example here, right? So as I go through this exercise, so this is a normal LV. How do I know? I put my eyes at a point in the center where my mouse is, and I see that the 2 endocardium, the 2 walls, are actually coming about halfway to that point in the center. So nice moving towards the point in the center. I also look at the thickness of the myocardium. You can see that it almost doubles in thickness in systole, right? So you see this nice thickening throughout the walls. And then I look at this anterior mitral valve leaflet, right? And in diastole, this thing flies open and comes within a 0.5 centimeter, almost touching the septum. So this is just normal LV function. And then similarly here on a short axis, I'm just looking to see that all the walls are coming to a point in the center symmetrically, and they are. So good squeeze there, right? So you guys get a sense of what normal is. And so that's all I did for you. I went through a little bit of the LV. I'm going to go through a little bit of the RV in a second, but let's just go into a few cases, okay? So I'll go through some examples of what shock looks like in a few patients, right? So here was one guy who 67. He was admitted for stroke, came in, a stroke complicated by pneumonia. He actually had a pontine stroke. It was like a small stroke in the pons, And he actually lost ability to swallow and talk. He actually had to be intubated because he couldn't protect his upper airway. But he slowly, the blood resorbed, he actually recovered, and he was extubated, and he went to our rehab floor. And this was during the years when I used to run RRT teams. We went to every RRT. Usually there was a fellow and attending. We had a big box for airway, and we also had an ultrasound machine. And so when we got to patients' bedsides, we'd have to figure out why they were crashing. And a lot of these patients were quite sick. But I used to generate a differential knowing where I was going, right? So if I was going to like the orthopedics floor, it was generally two things I would worry about, which is like either narcotic overdose, meaning like a little bit too much pain medicine, syncope because they tried to get up for the first time in a week, or sometimes it would be pulmonary embolism. And same thing with rehab is that there was a lot of syncope on rehab, but there was also PEs. And so I would already, you're allowed to think clinically with ultrasound. You don't have to just make pictures. You're allowed to think like a doctor. And so here was a guy that we had sent out from the ICU who suddenly there's an RT call. We get there. He's really short of breath and he's hypotensive. He was actually satting in the 60s and he was, blood pressure was in the 60, the old 60-60 rule. Not a good place to be, right? So this is a parasternal long. Don't look at this one yet. He can wait. He'll be fine. Actually, he couldn't wait and couldn't be fine. But let's just look at what you can say about the RV in a long axis. So in the long axis, this is the RV outflow tract. And normally it looks like a little triangle, and you can take a little bit of squeeze. This view does not give you a lot of information on the RV normally. And so basically, if you're looking at this view and the RV catches your attention, that means the RV wants your attention, okay? And so this is not a good view if you're going to find out an RV abnormality. So look at this normal kind of triangular RV outflow tract, and this is what I call the stink eye, right? So you see this big eyeball looking at you, and so now when you're looking, here's the LV that's kind of squished and underfilled, and now you see this big rounded RV outflow tract, and this is a problem, right? So if you see this, you have to wonder, why is this RV now rounded and so large, and also why is this septum not coming out, right? And so this is clearly already, if you have any experience, you can tell that this is acute RV overload. But we never go with just one view. So you guys want another view? I'm sure you do. Okay, I'll give you another view. So this would be what the short axis look like, right? So this is normal, right? We already went through that. You can see how everything squeezes and it's normally round, right? The LV has more pressure normally in the heart. The RV normally is a very low pressure system. In fact, the RV is less of a pump than more of a conduit. It's almost like the esophagus. It sort of peristalsis blood to the into the lungs, which is a low pressure system. So when you start to see a dilated RV that now has pressure that's impinging the LV, you got to worry that there's some serious RV pressure building up, right? And this is what we call the D sign, right? And so if you're not seeing the O and you're seeing a D, you got to say damn or something like that, or darn. How's that? And you got to worry. So here, this patient has clearly an RV that's almost twice the size of the LV cavity, whereas normally, right, this is much bigger than the LV cavity. In fact, in normal patients, it's almost like a little knuckle, right? There's like a little bit of blood coursing through the RV, whereas here, most of the volume is in the LV. And here's the opposite, right? So this is so large, it's actually affecting LV filling, and this is why this guy was in shock. Third view, we went to the IVC, and you guys can see, not surprised, right? A big IVC, it's a pressure gauge, right? It tells you that the right-sided pressures are very large. What else does it tell you? Well, if you're looking very carefully, your eyes might be drawn to a little bit of hyperechoic region in the IVC, right? Blood should normally be anechoic, and here you're starting to see some echoes. And then every once in a while, you see this thing kind of like, what was that? You see that kind of refluxing out. And so that's just badness. And what that is it's called either, basically the terminology is a clot in transit, right? So not only is this guy under high pressure, he's definitely already thrown clot, but now there's more upstream. It's bouncing around in the heart. And that's actually what massive PEs are caused by. They're usually a cord of clot that comes from the iliacs, right? Or from the femoral. And that cord of clot usually goes en masse to the heart. And that's why you have like these snake-like clots rolling around in the RV because it's this big cast. It's almost like a venous cast that gets stuck in the RV. And so this is what happened to this poor guy. A big chunk already went and impacted itself in the pulmonary arterial system. And then you also had clot rolling around in the heart. So this guy was in trouble. So if we go to our menu of reasons for shock, which pattern would we put this patient in? And clearly, right, you're going to put him in the acute cor pulmonale, which is a very dilated RV with some paradoxical septal motion. And you saw that in a few of the views. And also you saw a dilated non-collapsible IVC. Do not pass go. This is someone with acute RV failure. Now, how do you know it's acute? Because he doesn't have a history of it. It's the right clinical context, right? I'm not saying that every RV that you see that is big means that they're an acute RV failure. Everything's context. You have to think clinically. But, and sometimes I've been fooled because I've tried to differentiate shock states. In particular, when I'm faced with obese patients that I've never met before, you don't know their history of, let's say, sleep apnea, right? And a lot of times they have untreated sleep apnea with some RV problems, and sometimes you can overcall. But we actually knew his echo from the ICU, and here this was clearly an acute RV failure. So I'm going to move on. So that was RV shock. This was him. He went to the CAT scanner on the way to surgery because this guy, remember, he had a pontine bleed, so we could not give him TPA. And I called the surgeon from the bedside, and the surgeon actually came. He was in the OR within like an hour or two, and they took it out. So this is one of those kind of big Eureka saves, and this is that cast that was rolling around that they got out of there. And the guy actually did pretty well. And again, not every echo I do gives you this Eureka, big crazy save. In fact, most of the echoes I do, what they do is they help me and the patient sleep better at night, meaning I know I'm not missing anything big and bad like this, right? And so I'm reassured, and I'm able to focus my therapies on what is wrong and not on what might be wrong. So I'm going to go very quickly through a couple others, and then I want to cover lung. But you guys get the drill, right? Which is you try to put it into a pattern, LV, RV, valve, pericardium, and then see what fits, right? So here was a patient who came in, got called from the ED. They thought she was septic. She had some pyuria in the urine, and she was on pressors. And we went down. We put a probe on her chest, right? And so what did we see? So here, and as I look at the LV, I already kind of see a problem, right? I don't see that excursion. So I see kind of poor contractility of the LV. RV looks okay, right? A little triangular, doesn't look that big. And then obviously I don't see it in this view yet, but basically I'm already kind of worried that for someone in shock, you're seeing kind of hypocontractile LV, right? And then when you look at this anterior mitral valve leaflet, it's not flying all open and going to the septum, and you're seeing very little thickening. If anything, you're seeing thickening here at the base. This is the last region of the heart to lose function, but really almost akinetic elsewhere. So this is a very poorly functioning LV. And then you see fluid behind the heart, which is a pleural effusion, right? It's not pericardial. If this was pericardial, you guys know it would track in front of the descending aorta within the pericardium. The fact that it goes behind it like this tells you it's the pleural. So you got a pleural effusion and bad LV, right? So maybe this is someone with heart failure. Now, does this mean I should call the cardiologist and put in a balloon pump for this lady who's got a UTI? No. But what this does for me is clinically she was septic, but this is, in a medical ICU, a lot of times I find multifactorial shock. Basically, she had a very poor LV. She had a pacer wire, which was actually her defibrillator. And if you can see here, very poor contractility compared to the normal one over here, right? And so what she had is very poor reserve. And this woman actually wasn't peeing. She had a high lactate. She was on pressors. This is the 4-chamber. You can see the pacer wire here. And you can see very poor contractility, especially someone who's septic and vasodilated. You really should see the heart actually improve its LV function. So basically she had a chronic cardiac myopathy. Now, why was that helpful? It was helpful to know because her heart needed a little bit more support. It had no reserve. And so in this patient who wasn't peeing with a high lactate, who was already on pressors with a normal blood pressure, we actually added an inotrope. And this is one of those patients who did really well. And here's the IVC and here's the lungs, right? This was the 2 to 3 liters that the ED had given, with her chronic heart failure and high left atrial pressure. It went right into lungs. And this is B lines. And so she was already in pulmonary edema. We actually gave her an inotrope inotrope, and she did really well. And so although I would put this under LV failure, clinically, it was kind of vasodilatory as well as, so it was more of a multifactorial, but we did uncover the LV component. We treated it, and she did well, okay? And so this is one of those patients who just did great after an inotrope. Now, I want to be humble and tell you that I've uncovered a lot of LVs that weren't doing what I thought they would do, and I've given patients trials of inotropes, and some of those patients really disliked me and my bright ideas almost immediately. And so I have this sort of clinical clue that I give you, which is there are conditions where you think someone will benefit from an inotrope. I got news for you. Some really don't, but they let you know very quickly. Like if the heart rate goes crazy, they start getting hypotensive, that means they don't, it's not just the dobutamine, it means that they really aren't benefiting from an inotrope. But this is one patient who just did marvelously on it. She really came around. We treated her infection, and she went back to baseline. All right, I'm going to stop with the cases except to just show you the other two examples. So I showed you one of RV. I showed you one of LV. This would be a lady who came in septic, got fluids in the ED. We went and saw her. She was on a decent amount of pressors. And what did we see? Normal echo shock. This is really common, guys. So you will see patients in shock with this kind of echo. And so that's really common. And then this is another famous case that I always present. I'm not going to go into all the gory details, but this was actually a woman who routine vital signs were taken after dinner, and she had terrible vitals, and she was fine. She complained of nothing. She had just finished dinner. We got called from an RT. We went to her bedside, and I looked at her, and besides her looking a little pale, she complained of nothing, and we did a rectal. There was nothing from the rectum, but she was 80/40 and 140. And I'll just tell you guys, as an intensivist, especially in hemorrhagic shock, these are really dangerous vitals, because these are the vitals that a patient will have until they don't anymore. So they'll hang out around 80/40 with a sinus about 140/50, and then either you're going to resuscitate them and rescue them, or they will go bradycardic and they will arrest on you unless you reverse the cause. And so we really wanted to know what was wrong with this lady. So guess what we did? Yes, you are correct. We put a probe on her chest. What did we see? We saw this terrible, terrible echo. This is one of the scariest echoes in my collection, guys. It's very hard to find an echo of a patient like this. Again, I don't think I have any other echo that shows someone who's so close to death from hypovolemia. But look at this heart. See the volume in this heart? There's almost nothing. And so what I did is I reassured the room. I said, guys, calm down. The EF is 100%. And everybody calm down. This is my joke. Look, I got Jeremy to laugh. Thank you, Jeremy. So you like my joke. And then the intern tells me, Dr. Kory, EF of 100% of 10 mLs is, it's 10 mLs, Dr. Kory. And so I said, you are correct. The stroke volume is very, very low here, right? So there's almost no blood. And this patient was really actually exsanguinating. And where was she exsanguinating? We discovered this later, but she was actually exsanguinating into her axilla. There had been a PIC attempt the day before. They had done some vascular injury, and she was slowly bleeding. She had this massive hematoma in her axilla, and she was losing liters or units of blood there. So this is what her parasternal looked like. This is what her parasternal short looked like. And again, you can see there's almost no blood. And this, look at the RV. There's almost no blood in the RV. And so this is a patient who's just totally volume embarrassed. And the crazy thing about this case is this was the left upper chest, right? This is her chest wall. And if you guys look at that, can you guys see some of the twinkling there? That is her hemorrhaging into her chest wall. So not only do you find out that she's in hemorrhagic shock, but you also find out where she's hemorrhaging. So that's kind of a 2-for-1, and this is why it's a really cool echo. So I just have to show you guys that. All right, I'm going to change gears, guys. It is now, on my clock, well, you guys are on the East Coast, it's, 4:35 or 4:42 there. I'm going to talk about lung ultrasound. Hopefully you guys understood the concept, and you guys do this routinely. You use the 5 views, and you ask the 5 questions, and you put it into one of the 5 patterns, correct? Correct. Okay, so we're clear. What did I just do? Is this me? Hold on, now I had to open up part 2. I just closed it. Okay, now we're going to shift gears, guys, and we're going to talk about differentiating respiratory failure with lung ultrasound, right? So that's kind of like the sister to using echo to differentiate shock states, right? And so here, this is also a really cool image. You guys see this one? Let me mess with you guys on this one. So you guys are all clear. Jeremy, is this the diaphragm? Yes. And this is either the liver or the left-sided liver. So it's either the liver or the spleen. We're going to go with spleen because it looks a little small, right? Sometimes you can't tell. So this is the spleen. And so what's above the spleen? Well, normally the lung, right? A normal lung would just give you A lines or a curtain sign. But here you can see that the lung appears to be a solid organ again, right? And so when I saw this patient, by the way, just to give you the clinical context, this was a patient for whom the cardiac surgeons called me for as a pulmonary consultant to do a thoracentesis because she had a post-CABG effusion. Actually, it wasn't a CABG. She had an aortic graft placed. But she had a post-bypass effusion, and they wanted me to tap it. So I went and I did this ultrasound, and I looked and I said, oh, there's no stinking fluid there. Oh, the dumb surgeons, they think there's an effusion here. There's no effusion. And I said, this is just atelectasis or consolidation. And I was about to kind of walk away, but then I looked again. And as I looked a little bit carefully, I said, if that's lung, it's kind of moving in a way that's a little weird. Like it kind of looked like a lobe of a lung, but I've never seen the lung kind of look like jelly like that. And I thought it looked sufficiently weird. And guess what it was? Actually, this was a hematoma. So this is a huge blood clot sitting. This was basically hemothorax. And what had happened was her aortic graft was leaking. And so, in fact, the other thing that told me that there's more going on than just an effusion is when I went in there, the lady really didn't look well. She, normally when you do a thoracentesis for a post-CABG effusion, it's a pretty benign patient who might complain of a little dyspnea. This lady really looked very, very poorly. And so when I saw this is actually diagnostic of blood. When you can see this anechoic fluid surrounding this kind of gelatinous mass that's moving in this way, that's actually a floating clot. And so I immediately told the surgeons, I said, this lady's got a hemothorax, and I think she's bleeding into her chest. And this is where I love the surgeons, right? Surgeons, when you actually give them something like real to do, boy, can they do it. Like they had the OR open within like 10 minutes. People were running around. They put a chest tube in, and she was like wheeled off to the OR within like 10 or 15 minutes, and they fixed the leaking graft. Anyway, just a cool image. So guys, when I talk about lung ultrasound, I always do it in the context of diagnostic accuracy. I got to tell you, one of the things we do most poorly in medicine, the most common erroneous diagnosis in medicine is the diagnosis of shortness of breath. We do really poorly, even with all the training that we have. And this was a big report. It got a lot of attention about 5 years ago when it came out, and basically showed the millions of people who are harmed each year with wrong diagnoses. And they come in kind of three flavors. Either you miss it, you delay it, or it's just flat out wrong. And the most common one is differentiating heart failure from pneumonia. I got news for you guys. Procalcitonin and BNP, they'll take you some of the way. They're not going to do all the work for you. I know you guys love those two tests, but sometimes even with those two tests, it's still hard to differentiate. And so that's where lung ultrasound really shines. And just to show you guys, this is all from kind of ultrasound studies, how poor we are at diagnosing acute dyspnea. And what I find shocking about that is that what is the differential of acute dyspnea? It's not like some morbilliform rash of the chest where a dermatologist gives you like a differential of 75 causes, right? If you're acutely short of breath, it's generally one of what I call the big four. And I lump COPD and asthma together. They're both obstructive lung diseases. So it's generally COPD, asthma, pneumonia, pulmonary edema, or PE, right? You could throw pneumothorax in there, but I don't really, because that usually has a pretty good clinical context for it. But generally, those are the big four that are going to acutely cause you to be short of breath. It's an infection, it's heart failure, it's wheezing, or it's a vascular problem, right? And so how good are we? Well, in these studies, this is an elderly patients coming in with acute shortness of breath, 20% misdiagnoses. In the emergency room, when they looked at the initial diagnosis placed by the emergency physician and then the final one after discharge and full workup and everything, only 50% accurate. So wait a second, you're telling me that one of my daughters could get 25% accurate just statistically flipping a coin or just taking a guess. And after 10 years of training of medical school and residency and everything, we're only can get that up to 50%, right? Here in this other ultrasound study, the agreement with the final diagnosis was really, really poor. Similarly, 50% incorrect initial diagnosis, and then similarly, a lot of missed life-threatening. This is a really cool study. So this is a study where they took two senior Italian intensivists. One was the director of the unit. The other was a professor. They'd done decades of critical care. And this is what they did. They presented patients in respiratory failure to these two intensivists. They had the X-ray, the EKG, the BNP, the D-dimer, the Procal, whatever they had back in those days. This is about, I think, about 10 years ago. And when they got all the information, which is history, physical, all of that, the doctors came up with what they thought the patient was in respiratory failure from. And guess what? They were 63% accurate. But guess what they did? They called on two sono intensivists, two young whippersnappers with an ultrasound machine. And they said, go examine that guy and tell us what's wrong with him. How accurate were those two blinded sono intensivists? Well, I didn't put it on the slide, but they were actually 83% accurate, knowing nothing about the patient, nothing on the film, anything, just doing a lung ultrasound. They achieved pretty high levels of accuracy, far more than what traditional tools do. This was a really scary study that came out about 5 years ago, where they took everybody in an ED who the ED doc thought had community-acquired pneumonia. So anybody who came in who they thought had pneumonia, they just ran you through the CAT scanner just to see what it would show, to see how helpful of a test it was. And guess what they found in this huge population, 300 patients thought to have pneumonia. Guess what? 1/3 did not have pneumonia, even though they had an opacity on the chest X-ray. So a third of them went an abnormality in X-ray, had nothing on CAT scan. And then this is much more believable. 1/3 who had a clear chest X-ray had something on CAT scan. So it just tells you that the point of this slide is that chest X-rays are very limited tests, guys. We don't talk about it enough. It's really a crappy test. Yet we rely on it constantly. And although I put down this constant search for the pulmonary embolism, it does lead you to an important diagnosis a lot that's not PE. And so most of the patients, the vast majority, were reclassified as far as the probability, and sometimes by two classes. And so it showed you the wealth of information that a CAT scan could bring compared to an X-ray. And so they basically excluded pneumonia in 30% of patients who were about to be admitted for treatment of pneumonia. And this is what I think is really funny, is antibiotics were discontinued in only 9%, which means that they're not following the Cory Rule. I have a lot of rules that I teach my fellows, and one of the Cory rules is you cannot have a pneumonia with a completely normal CAT scan. I will not allow you to treat pneumonia if you have a normal CAT scan. So nobody here heard the Cory Rule in that study. And so here's the point, guys. This chest X-rays are really limited. They either overcall things or undercall things. In a heart failure registry patients, 20% of them had a clear chest X-ray, or they all got admitted with heart failure, right? And then 1/4 of them got a non-CHF diagnosis. So we're constantly getting things wrong. CT scans really they are miracles of modern medicine. I got to tell you, as much as I put them down because we overuse them, I find them to be amazing tests. In fact, I think they really are a miracle. They give you so much information about the lungs, but they're impractical, right? We overuse them. So is there an alternative? There is, guys, and I'm here to tell you it's lung ultrasound. So lung ultrasound is what I call the poor man's CAT scan. So I'm going to go a little bit quicker. That was also a similar study showing the same thing. And so what is that test? So if you look at, just for a diagnosis of pneumonia, let's look how lung ultrasound compares to chest X-ray, right? So this is the specificity of lung ultrasound versus chest X-ray, and this is the sensitivity. Look at the sensitivities of lung ultrasound for a pneumonia. If you come in with clinical signs of a pneumonia or symptoms, we're going to find it with lung ultrasound, and we're going to do it quite specifically. Look at the sensitivity of chest X-ray. We all know, right, especially a portable chest X-ray, you're missing almost 1/3 of the lung, right, behind the domes of the diaphragm in the back. And so you would know that at best your sensitivity is going to be 70-80%, and here sometimes it's lower. And so just to, guys, let you know how lung ultrasound performs in looking just for pneumonia. This was a smaller study done in an ICU looking for the other conditions that we often touch. So interstitial syndrome, which is to say sort of heart failure, right? Look at the sensitivity and specificity of lung ultrasound compared to chest X-ray with, and this was, by the way, CAT scan was the gold standard. And so when I say that lung ultrasound is a poor man's CAT scan, this is one of the studies in which I do it. The sensitivity and specificity rivaled the CAT scan. And when you try to do that with X-ray or auscultation, it does not work very well, right? And so I don't think, no, this isn't the study where they use the stethoscope, but there's a similar study where they use the stethoscope, and I don't even want to tell you guys the numbers. They were so poor for the stethoscope. But so this is just to show you that there's good evidence showing that. What lung ultrasound is good for is if you're sick enough to be short of breath or in respiratory failure, it's the pathology is going to involve the surface of the lung, and you're going to pick it up on your surface scan with a lung ultrasound. Okay, I'm going to skip this study and just go to some examples. Oh, this is a really cool study because this talks about the perils of diagnostic inaccuracy. So in this study, what they did is they took a whole bunch of patients who had heart failure. They had no heart failure. They were in a registry. And they looked at who got treated, who got admitted, and who got treated for pneumonia. So if you got treated for pneumonia or if you didn't get treated for pneumonia, your outcomes were about the same, okay? If you looked at the subgroup of patients who had a high procalcitonin, which is to say suggestive that they might have a pneumonia, and you treated them, guess what? They did really, really well. If you had a high procal and you didn't get treated, which means maybe they missed a pneumonia, there's got to be some reason why there's this huge divergence in curves. It tells you getting the diagnosis right is important, right? Differentiating heart failure from pneumonia or the coexistence, right? Sometimes pneumonia can cause a heart failure exacerbation is really important as far as saving lives. Now, look at the next slide. Here, they looked at patients with kind of in-between procals, right? Which is most every time I send a procal, it's rather unsatisfying. It's never totally normal. It's never totally abnormal. And here you had a small signal that if you treated them, they actually did worse, right? So the less likely it was and you treated them, they did worse. Now, can you guys explain this? If you didn't have a pneumonia, let's say you pretty much effectively ruled out pneumonia, yet you were treated for pneumonia, you did really poorly. And when I ask groups of people to explain this why, I'll give you some of the answers I get. Number one, it was the fluid from the Zosyn and the Vanco. Okay, maybe you overloaded them with your IV antibiotics. Probably not the case. You can easily diurese that away. What are some other reasons? Yeah, basically they worry that somehow the antibiotics hurt them. Because there's other studies showing similarly, if you treat patients with heart failure with bronchodilators, they do worse. But I got to tell you, the problem is not the medicines they receive. The problem is there was a wrong diagnosis being treated, meaning the patients came in with heart failure and you treated pneumonia, which is you put insufficient attention, you anchored on the pneumonia, and you didn't treat the heart failure, and that's why they did worse. And that's why I think conversely here, you treated the pneumonia instead of the heart failure. And so it's really about erroneous diagnosis, and you get anchored on something, and I think that's really where you get things wrong and you can harm patients. So let's talk about lung ultrasound, guys, really quickly. One of the things I love about lung ultrasound is that it's hours. When I say hours, it's pulmonary critical care. It was invented by an intensivist. In fact, he's a nocturnal intensivist. He works almost only at night, Dr. Lichtenstein, who I've gotten to know over the years. Very interesting guy. And he just started putting the probe on everybody. And he started looking at lungs like in the late 80s. He just started looking. Basically, this is what you see in most everybody. It's really not a very interesting image when you look at a normal lung. This is what the normal lung looks like. All you see is a little bit of movement, which is the parietal and visceral pleura, or the parietal pleura moving against the visceral pleura. And then you see this reverberation artifact, which is just air. It just means that the lung is full of air and you get this artifact. So it's not very interesting. But what Lichtenstein noticed is that as patients got sick, this pattern changed. And how did it change? I'm getting up to my time. I'm going to stop in 2 minutes. I'm just going to probably end on this slide. Or actually, I'll show you one more slide, which is the heart of this talk, and then I'll stop. But what he found was that the pattern at the pleural surface changes according to air fluid ratios. And that's basically how you should think of lung ultrasound, which is if you have a lot of air in the chest, which is to say more air than you should, like air in the pleural space, guess what? That air will serve as a barrier. You will not be able to see the underlying visceral pleura sliding. And so you'll see this very static image. And that's how you diagnose a pneumothorax. The normal lung, these interlobular septa are so small that ultrasound cannot propagate through them. So you get these repeated A lines. And so you can't see these widened interlobular septa as you can like when you get pulmonary edema. So either hydrostatic or permeability edema, you get sort of fluid in the interstitium and in these interlobular septa. And now ultrasound can penetrate and now you can bring out these B lines. And so ultrasound's really good at differentiating kind of dry normal lung from wet lung. And then as that air fluid fluid ratio changes as you start to flood the lung, then you get more of a consolidation. All of the alveoli fill, and then you get those beautiful images I showed you before, where you can see like the lung kind of looks like the liver. And then if the fluid continues and you get fluid in the pleural space, now you can pick up an anechoic space outside the lung, right? So everything's about air fluid ratios. And so these are the 5 nomenclatures. One is sliding lung, A lines, B lines, consolidation, and effusion. This is what you guys should know, right? This is what the A line looks like. This is why it's formed this way, right? So it's this is the rib shadow. This is the chest wall. This is one rib shadow, another rib shadow. You always want to look in between the ribs, and the first curvilinear line deep to these rib edges is the pleural line. It's made up of visceral and parietal pleura. And if there's air underneath, basically what happens is the ultrasound wave bounces off this visceral pleura, goes back to the probe, and then bounces off the probe and comes back and then returns. And it tricks the ultrasound machine into thinking that there's another tissue plane deeper and deeper in the lung. And that's just because the ultrasound beam is bouncing around in the soft tissue. And that's why we call it an artifact. And that's why I say it fools the stupid ultrasound machine into thinking that the normal lung looks like kind of like a layer cake, which it doesn't, right? And so this is what it looks like in real life, right? So this sliding lung, this is where you can tell that there's no air in between the pleura, because you can see the moving visceral pleura, right? So as long as you can see it, it means there's no air in between. So there's no pleural air. And what is the underlying lung pattern? Well, it's an A line. You see this reverberation of the pleural line. So this is dry lung, right? And this is how, this is like a little graphic showing what a pneumothorax would look like. So here you get sliding lung. What happens if you pop a pneumo and you put the probe on then? Well, what happens is now you have separation between the visceral and parietal pleura, and that blocks the probe. And so what do you see? You're going to see this. And I call this the ominous quiet of a pneumothorax, right? So if you ever see this where you do not see that dynamic twinkling or shimmering, you know you're in trouble and there's probably pleural air. And what you're seeing here is the parietal pleura, but you cannot see the visceral pleura because this person has a pneumothorax, okay? And that's, again, what it looks like. This is the ominous quiet. Now, you do see movement in the image, right? And usually there's 2 things causing movement. It's either the nervous operator who just popped the pneumo with the central line, right? Or it's the very dyspneic patient who's trying to breathe. So there's movement, but you want to train your eye here, and this is too quiet for me. There's no independent twinkling, shimmering, or sliding, okay? So that's a pneumo. This is B lines, right? So A lines, B lines, sliding lung, and then consolidation I showed you guys before, and then a big old pleural effusion, right? So you guys get the 5. And then how do we differentiate? Well, this is, I'm gonna stop here, but this is how I differentiate respiratory failure. So when I do a lung ultrasound, and this is how I do it, I do a 3-point. This is upper lobe, middle lobe, and lower lobe. So if a supine patient, I make sure I get behind the posterior axillary line, and I make sure I image back there. So I do 1, 2, and 3, and then I do it on both sides, and then I try to put it together. So what does pulmonary edema look like? Well, basically, you're going to find B lines bilaterally, right? So if you see this, this is going to be generally pulmonary edema. And so if you see it bilaterally, and keep in mind, if you see B lines in all interspaces, that means they're in horrific pulmonary edema. Most patients in acute pulmonary edema with short of breath, you actually are only going to generally find B lines just at the middle lobes, because the more sick you are, the more B lines you're going to see. You're going to see them in upper, middle, and lower. In general, you find patients which is bilateral. So if I find patients with bilateral B lines at 0.2, that's generally pulmonary edema for me, and usually hydrostatic. You know, if it's ARDS or permeability edema, it looks a little bit different, and I could talk about that some other time. But bilateral B lines would be pulmonary edema. Diffuse A lines would be either COPD, asthma, or PE, right? So if you have dry lung and they're short of breath, either they're not moving air or they have a PE, right? It's either vascular or an airways problem. And there you could do a DVT to differentiate that out. And then pneumothorax obviously would be absent sliding. And then pneumonia can be a bunch of things. So it can be patchy or unilateral B lines. It can be unilateral consolidation or a consolidation at the base with a small effusion. So pneumonias can take a few different things, but notice how similar this slide is to the slide I showed you for the heart. And these are the 2 concepts I want to leave you with. I'm going to stop here, and I'm going to tell you that this is the things that you need to take into the unit, which is when you're trying to figure out why someone's short of breath or in shock, you try to put it together in these ultrasound patterns, either cardiac or lung ultrasound wise, and then this will give you the diagnosis, right? And I'll finish with my famous slide, which is I talk about this landmark paper that Lichtenstein did, because I get to use a French accent. So I have a pretty good fake French accent. So this is Lichtenstein, and this is how he did his study. He basically went to the ICU team, and he said, you will call me when you admit a patient with respiratory failure. As soon as you admit them, you will tell me nothing. You do not tell me about their chest X-ray. You do not tell me their history. I will perform my ultrasound and I will tell you what is wrong with them. And so that's what they did. So similar to that other study, they called him and he just did his ultrasound. And how good did he do? Well, he did throw out about 15 cases in these 216 patients who didn't really have a diagnosis or had like multiple diagnoses. But in the rest, he was 90% accurate, totally blinded by doing a lung ultrasound and a DVT. He was almost perfect at determining who had pulmonary edema. He was very good at PE, pneumonia, as well as COPD asthma. So it was a landmark study, and I'm going to stand there. Hopefully, you guys will get to be as good as Lichtenstein was. Okay, I'll stop there, Jeremy. Hopefully, that was good, and I didn't go too over time.
No, it was fantastic. Thank you so much for going through a wonderful presentation and hitting so many highlights about the uses of ultrasonography and cardiac and respiratory failure. For our participants, we are over time, so we're going to unfortunately hold on questions. There were none that went into the chat, so we're not missing anything critical or burning.
Okay, because they're all expert, Jeremy. That's why I can't teach them anything anymore. Like my whole gig is up, man. Everybody knows ultrasound now.
It's a high-level group. That being said, the evidence-based context that you put everything in, as well as going over the steps that are needed to do a point-of-care ultrasound, I think are going to benefit their skills going forward. We'll find out because, as Rebecca just put in the chat, we'd love for you to fill out evaluations about Dr. Shelley's talk, about Dr. Kory's talk, and about the Fellows Track Symposium overall. These are recorded. You can access them through the Fellows Track Symposium on thoracic.org. And any feedback, comments, we'd love to hear from our participants. Thank you all for being here. You've been sitting for 2 hours, so please get up, move around. And Dr. Kory, thank you one more time for a wonderful presentation.
Great. Thank you. Thanks for having me. Okay, guys. Take care now.
All right. Bye.